Hi, I'm Dr. Kivett in Santa Rosa, California. I'm board certified in plastic surgery and dermatology and have extensive experience as part of my hand fellowship training as well as during the plastic surgery training with thousands of hand case repairs and other interventions toward helping the hand and the arm and the upper extremity in general. I'd like to speak today about nerve injury and repair. Nerves develop when you are the size of a grain of rice in your mother's womb, and the spinal cord controls a great deal of what happens. The pre-programmed cells that emanate from that central back spinal cord are programmed to line up, fuse, and form nerves. Those nerves, of course, are the cables that form the nerves that conduct electricity from the brain through the spinal cord to the periphery, meaning fingertips, toes, muscles in between, GI tract, and those nerves that also receive sensations through little nerve detection devices at the tips of your fingers and toes and in your skin in general, and push those sensations by electrical means to the brain where they're perceived in various ways, whether it's ants crawling, vibration, heat, pain, tickling, weight, pressure, all these types of things. The cables are kind of like the coaxial cables that you have in your electronic setup at home, the monitors, the connections between the computer and the monitor, television screens, and so forth. So it's basically a large lined tube followed by a variety of little tinier tubes inside of which of those are tinier tubes, and so on. And so by virtue of movement of sodium and potassium across the membrane that is part of that nerve tissue, signals of electricity and movement of electrons are perceived, and that's how our body works. The locations of the nerves with respect to today's discussion is that of the hand versus the forearm versus the upper arm. And through each of those different compartments that we've titled for discussion in daily life, there are points where those nerves can become compressed. And then if you look at accidents, the nerves can get crushed, they can be stretched, they can be partially cut, or they can be fully cut. And those changes have been identified and studied at length as to the possibility of their recovery without a doctor's intervention versus the necessity for the intervention. It's important in all cases, if there is a wound causing a problem, then that wound, is it clean or is it dirty? And if it is, what was the mechanism of injury? And so this is the premise with which we start. Now, this is different than talking about blood vessels. Blood vessels can be repaired, sometimes ignored. Nerves have a secondary problem, and that problem is that since nerves are one continuous stream of electricity, if you will, then wherever the nerve is damaged, anything downstream from that quickly degenerates within just a matter, in some cases, of a few dozen hours. And so that nerve needs to be repaired or understood, at least in terms of the potential impact to the patient. So the tissue's ability to regenerate has a particular type of way of doing so. Where two nerve endings are cut, one would think that you simply can have them put back together, and in fact, that is one good way to do it. The thing is that on the upside, meaning the brain side, compared to the downside, meaning the periphery, the fingertips, and so forth, that connection has to be one in which the tissue from inside these little tubules is lined up as best possible so that the living side can now move down the tubules, where the now isolated side, isolated by the cut, is starting to degenerate. And so if that living tissue early on can be hooked up, it'll move on down through the tubes of the now dying nerve tissue. If that doesn't take place, then there's problems. And so the way to help move things along is to quickly clean the wound, repair the nerve endings, and eliminate infection or infection potential. An infection around a nerve frequently will render it useless, whether it's a teeny tiny nerve or a reasonably good-sized nerve that powers a muscle. If there is scar tissue because there's a delay in repairing the nerve, then that scar tissue frequently will interfere with the movement of the healthy living nerve tissue through the now dying nerve tissue tubes. And so the ideal recovery of that nerve is compromised. The side-to-side suturing is good. Sometimes as nerves are cut, or if injury is severe enough, then one will end up losing the nerve tissue completely, and there's a gap that can't be closed because the nerve can stretch only so far. So in that case, a nerve graft from the patient themselves, because there's some nerves that aren't used very much and can be used, or from another person, a nerve graft can be brought into place, or a nerve scaffold, that is to say, the tube, something like one tube is called Axogen, AXOGEN, and so that scaffold can be put there to help surround the gap so that the nerves now see themselves being able to grow in the right direction, hooked up to the other now dying nerve tissue in the tubes. Other methods to help things are what has been described in the not too distant past by Dr. McKinnon in St. Louis and others as to nerve transfers, meaning a nerve is simply planted into a muscle where the otherwise intact nerve has been lost, or into other muscles. In other words, if one muscle doesn't work, but you're looking for a certain action to take place, then another muscle could possibly substitute. But if that nerve has been damaged, if you can plant that nerve into that muscle without having any major nerve into which to tie, sometimes that alone will allow the nerve to search out with its little buds of tissue and hook up where it needs to. Pretty amazing. There are free nerve grafts that can be also attached to small arteries in their native state. And if the nail healing bed is scarred, not giving sufficient oxygen to the tissue, then the nerve graft, together with a little blood vessel attached to it, can be brought into place, and the vessel sewed as well as the nerve, thereby giving oxygen to the new nerve setup. More commonly is seen small cuts, small injuries, where and the injury can be accidental, or the injury can be during surgery, where some nerves are so tiny that they're not even really visible very well to the magnified lenses of the surgeon. And frequently just lining up the tissue, if it's an accident, or in creating a wound to accomplish some other goal, can allow, if the tissue is brought together pretty nicely, allow the nerve endings to kind of find each other and start the process. However, if that doesn't take place, and so the nerves have now shifted a little bit by virtue of swelling or moving some tissue around to accomplish soft tissue closure, then the nerve endings here, in search of its brethren across the gap, will never be requited. It'll never be satisfied because it's up here, and the partner down here won't ever see the nerve endings here. And so that little cocktail onion kind of look of the nerve clumps that come out there are unsatisfied, they don't work, and most importantly, they are what we call neuromas, which we call non-cancerous nerve tumors, and they're simply just hypersensitive sensory bodies that even at rest or even during sleep, much less when you're using a hammer or picking up a cocktail glass, do you get this painful shooting sensation, whether it shoots far or not, is immaterial. What is more importantly is that it is exquisitely sensitive. And people say, Doc, either fix it or destroy that nerve. And in some cases, destroying the nerve is preferable. In other cases, if there's a nerve exploration for these tiny nerves, which is not that successful, then at least the pain is relieved, no matter the resultant loss of sensation, for example. Um, Neuropathy is a term that is used in people whose nerves are injured, as in diabetes. And so people who have numbness in their fingers and toes for a variety of reasons, including diabetes. Someone who has been uh, unfortunate enough to have an amputation of a portion of a limb, either at the finger or the hand or the arm level, or some other cause, will have what they call phantom changes. And so they have a painful finger that now no longer exists, but their brain still perceives a finger there. And so that needs to have special consideration and treatment as well. If nerve repairs don't work, or they don't work ideally, then the field was really advanced significantly by Paul Brand, MD. He was an acquaintance of mine before his untimely death at 92 years of age in Seattle. And he was raised in India in an English family and was sent to England to get medical training and trained in orthopedic surgery. And then after some training time there, returned to India, which was the homeland that he knew better and where he had known people with a variety of things, including paralysis, many of which had leprosy. And leprosy has a number of implications to a lot of people, but leprosy is simply an infection with a mycobacterium, which is kind of a cross between a bacteria and a fungus organism. And if the patient has an infection from the leprosy, then the nerve endings in many cases are affected. So the person loses the sensation that they normally would have. So in the old days, in the Bible particularly, they thought that maybe leprosy would eat away the fingers and so forth. And what was found ultimately to be the case was that something Dr. Brand described after his return to India, and that is he would see a man with leprosy whose fingers were numb and who would be very frustrated trying to open the door of his home with a key that he couldn't feel. And so he would be continuously trying to push the key, couldn't feel it, hitting his hand against the door, and ultimately causing wounds, which, with some accumulation of those experiences over the years, would cause the fingers to be damaged, get infected, partially lost to tissue, and so forth, thereby explaining what was thought to be some kind of intervention at a divine level hundreds of years before all of this technology was available. So if the nerve sensation or the nerve motor electricity from the brain to the muscles is disrupted in either the median, ulnar, or radial nerves particularly, then Dr. Brand described a series of what he called tendon transfers in those people who had, by accident or by leprosy or some other reason, lost the use of that nerve and therefore the loss of those muscles. So he said, well, we have at least 3 major nerves beyond the forearm, and so let's see if we can do something with it. And so his plan was that if a certain nerve was completely out, not working at all, then he had devised a way of making the nerves to the other muscles that were intact useful by transferring the tendons from emanating from those muscles over to take over for the function of the now lost muscles. Even though they were still attached to the nerves weren't working. The interface between the nerve and the muscle thereby degenerated, but you could bring in substitutes driven by other nerves that weren't affected, and therefore, if a person had a median nerve out, you could use muscles from the ulnar nerve and from the radial nerve to substitute for those of the median nerve, and all those permutations, different crossovers. And so it was a huge contribution to the to the field in general. So the key is, if there's a nerve injury known or suspected, it's best to get a very quick evaluation by people who do this type of work. And so you can help weigh in against that phenomenon as described by Dr. Waller many years ago, called Wallerian degeneration, so that the nerve tissue can quickly be restored in time. So if this has been valuable to you or to a family or friend, please let them know. Please issue a comment or a question if you wish. If you could give us the thumbs up, we'd appreciate it. And always, a subscription to this channel will allow us to continue to provide educational services on these issues. Thank you for listening.